I'm Linda Creegan. For many years, I've worked as a nurse practitioner at City Clinic, the public health department's STD clinic in San Francisco, California. City Clinic sees hundreds of patients with STDs every week, and it's also a teaching center. So the nurse practitioner students, the medical students, the residents, and the fellows all rotate through to learn about STD management. And of course, a big part of STD management is learning to take a sexual history. So from my own experience with patients, as well as from working with others who are learning about STD care, I can assure you that taking a sexual history is not a talent that some people just happen to be born with. Just like listening to a heart or looking in an ear, the sexual history requires skills that need to be practiced again and again. Today we're going to be talking about those skills, but first let's look at how the information we gain during a sexual history is helpful in patient care. The information that we learn from taking a sexual history helps us to individualize our patient's STD and HIV-related care and prevention. This is the information that's going to guide my physical exam, that will help me to decide what types of STD tests need to be taken. It, in the long run, will help me to prevent those serious sequelae that can happen for patients because of STDs, particularly my women patients, things like PID and infertility. And the information that I learn about risk will help to guide my risk reduction counseling. So we'll start first with a typical patient scenario. Here we have Charles, who's 25 years old. He gives us his reason for visit. My girlfriend has trichomonas again. It turns out he was treated about a month ago when they were both in Seattle. Now he's come back to the Bay Area to return to college, and he's a new patient at my clinic. There are at least a couple of red flags in this statement that would make me want to consider taking a sexual history. Trichomonas, because that's a sexually transmitted infection, and again, because something led to this infection again. I think we would all agree that when an STD is apparent in the picture, as for Charles, it's definitely important to take a sexual history. But how are clinicians about including the sexual history routinely with their clients? Well, admittedly, not as good as we would like to be. In survey after survey, clinicians say that they take the sexual history half the time or less. Now, these are not bad clinicians. I'm sure that these are very good and caring clinicians, but they're also very busy clinicians. In the press of all the patient's acute care needs, I know that preventive health issues and sexual health care in particular often get sort of pushed to the back seat. We really have to be able to do this quickly if it's going to get done routinely. And clinicians will often say that they're not 100% sure about what to ask, and probably even less confident about how to ask. Who's most at risk for an STD? On the slide behind me, on the left-hand side, you see a couple of demographic risk factors, starting with young age. Adolescents and young adults are those most likely to have STDs in the United States. And as with many other health problems in the United States, STDs and HIV disproportionately affect those in ethnic and racial minority groups. On the right, you see some sexual practices that confer risk: a new partner, multiple partners, perhaps a partner who has other partners. And these behavioral risks I would only know about if I asked my patient the questions for their sexual history. So back to Charles now. How might I begin my sexual history? I want to introduce the topic using a statement that would normalize the sexual history questions, also that acknowledges that this is pretty personal information I'm going to be asking about. Also to stress that there are important health issues that are related to his sexual history, and to emphasize confidentiality. So something like, Charles, I'm going to ask you some questions now about your sexual history. I talk to all my patients about their sexual history because it's an important part of their health. I know that this is very personal information, but everything that we discuss is kept confidential. And almost always, after beginning like that, the patient will say, okay, and they answer all my questions. It's really the out of the ordinary circumstance when a patient says no. But for the occasional time when a patient says, do I have to answer that? My response is always no. You don't have to answer anything that you don't want to. The reason I'm asking is because I find that if I can clearly explain the reason for the question that I'm asking and how I'll use that information in the patient's healthcare today, almost always I will get buy-in. So here's a nice way to organize and remember the content of a brief sexual history. Using the 5 Ps, I'll ask my patient about what past STDs they've had, if any, their pregnancy history and plans, who their partners have been, what their sexual practices have been, and what they do to prevent STDs and HIV for themselves and their partners. Using the 5 Ps for Charles, I begin by asking about past STDs. What other STDs have you had, if any? Then I ask about partners. Have your partners been men, women, or both? Or I might say guys, girls, or both. And I'd also want to ask, how many partners have you had since that last treatment for trichomonas? Next, I want to find out about his sexual practices. What types of sex have you been having with these partners? Then I would ask some questions about prevention. What do you do to prevent STDs and HIV for yourself and your partners? And about pregnancy history and plans. Do you have any children? What do you and your girlfriend do for birth control? Here's what Charles answers. He had gonorrhea when he was 20. He's had 3 partners in the past 6 months. His girlfriend, also a male buddy who occasionally gives him oral sex, and a prostitute who he was with recently in Las Vegas. He doesn't like the idea of anal sex with men, and he knows that HIV does not pass easily by oral sex. He has no children. His girlfriend uses the pill. He doesn't use condoms with her. He says, I'm her only partner. And he also did not use a condom with the woman in Las Vegas. He said that was a very out of the ordinary thing. He's never done such a thing before. He was drunk at a bachelor's party, didn't have a condom with him. So, by organizing my questions around the 5 Ps, did I get useful information? Information that I could use to direct my physical exam, to decide what types of tests would be good for him to have that day, and to help in my risk reduction counseling for Charles? I would say that I did. So the 5 Ps help to summarize the content of the sexual history. Let's talk now about how to approach these questions. Open-ended questions really are indispensable in asking a patient for information about their sexual history. And these are our who, what, when, where, and how type questions. As opposed to leading or closed-ended questions, those would be your are you, have you, do you questions. If you think back to Charles, most of the questions we asked him were phrased in a neutral, open-ended kind of a way. If we get hung up, you have some trouble changing a yes-no topic into an open-ended one, a handy way to do that is to begin the sentence with, tell me about. So instead of asking, do you have discharge? I might say, tell me about any symptoms you have. If I want to ask about condoms, rather than saying, do you use condoms? I might say, tell me about using condoms with your recent partners. For virtually all young sexually active people, condom use is not a yes-no topic because they use condoms with some partners but not others, or some of the time but not always. And really that's the kind of detail that I would like to have. It's also important not to make any assumptions about our patients' behaviors. I think we're past the most egregious assumptions. For instance, well, he didn't look gay to me, or she's married, so surely she wouldn't have sex with anyone other than her husband. And yet subtle assumptions seem to sneak in almost every time that I'm interacting with patients. It is something I need to watch myself carefully about. I think the most common assumptions that new clinicians make when taking the sexual history have to do with number or gender of partners. So the young man who comes in and says, my girlfriend asked me to have an STD check. I would be making 2 assumptions if from the word girlfriend I thought he only has sex with women or that's his only partner. I still want to ask him, have you had sex with guys or girls or both in the past? I also want to ask how many partners have you had in some defined recent period, like say the last 2 to 6 months. Then I can go on to ask about specific sexual practices. I find that most patients know the anatomic terms for the various sexual behaviors, vaginal sex, anal sex, and oral sex. So I usually start with that terminology myself. If I have a man who has sex with women or a woman who has sex with men, I try to avoid using the term regular sex to refer to vaginal sex, because that, of course, implies that everything else is irregular or abnormal. And if I'm asking about anal sex or oral sex and the patient doesn't understand, the patient will ask, "What's that?" In which case I describe in a little bit more detail the behaviors that I'm talking about. Do you put your penis in her behind? Do you take his penis in your mouth? I don't find, however, that I have to use slang or what feels like dirty language to me in getting an accurate description of the patient's sexual practices. If I'm talking to a male patient who has sex with men, there are two types of sex that I want to find out about: anal sex and oral sex. But here I find that the terminology about insertive and receptive is a bit cumbersome and confusing for patients as well as for clinicians. So here's a nice, concise sentence that can get to all that information very, very quickly. Are you having anal sex? And if so, are you top, bottom, or both? Top is the insertive partner, and bottom is the receptive partner. Some men will say, "I don't have anal sex." Some men will say, "I have anal sex when I'm in a steady relationship, but I'm dating now. I'm only having oral sex with my partners." Some men will say, "I only top, I only bottom." Some men will say, "I'm versatile, I go both ways." You get the whole range of answers, and you can see where that detail of information is important for deciding who's most at risk for various infections, what kind of exam I need to do, what type of tests I might need to take. It's also important to avoid medical jargon. This also seems to sneak in pretty readily when I'm talking with patients. Rather than asking the patient, "Have you noticed any dysuria? Is there any exudate from your urethra?" I would want to put that in clearer, more simple patient language. So something like, "Is there any discharge from your penis? Does it hurt when you urinate? Is there pain when you pee?" I often find that patients need a little bit of encouragement to talk. Patients are nervous when they come to us for an STD check, and sometimes feel like they have to say things in just the right words. They're not sure of those words. So if I ask a young woman, "What brings you in today?" and she says, "I'm not sure how to explain," I might say, "Say it in your own words. Just go ahead and say it however you like." And then she can relax and say, "Well, it itches down there," or "I've noticed some brown stuff," or a young man might say, "My stuff is burning." I need to ask a couple more questions then to clarify that, to make sure that I understand what they're talking about. Is it your penis that hurts when you urinate? Does it seem to be brown discharge coming from the vagina? But the patient is much more relaxed if he or she is able to state their problem in their own words. Another nice technique for encouraging patients to talk is to give the patient a range of behavior and ask them to place themselves in that on that range with their own experience. Here's what I mean by that. If I have a young woman who's sitting in front of me, I might want to ask her whether she's sexually active. So I say, "Some 16-year-olds who I see have started having sex, and others have not. How about you?" Or if I have a fellow who I want to open the conversation about condoms with, I might say, "Some men who I talk to use condoms pretty much all the time and take them for granted by now. Other men really hate condoms and have a lot of trouble using them. How's that been for you?" And you can see how what that says to the patient without directly stating it is, "I talk with people about these subjects all the time. I've heard lots of stories, and whatever you tell me is important to me. I want to hear your experience." And a nice open manner with lots of active listening cues helps the patient to keep talking. So eye contact, head nodding, "Yes, go ahead, keep talking, I'm listening," can help the patient to get their entire story out. Finally, we try to maintain a non-judgmental attitude. To me, this involves two important factors. First, recognizing patient anxiety, and secondly, recognizing our own biases. Let's talk a little bit about each of these factors now. We are human beings, and we have our own values and beliefs just like our patients do. We are 100% entitled to our own values and beliefs. However, our job as professionals is to keep those out of the way when we're dealing with patients. Being non-judgmental means we are willing to listen and that we want to hear the patient's true concerns. So, thinking about anxiety now, there are many, many different expressions of anxiety. Some patients will sort of withdraw from me, Let's say he won't take off his baseball cap, he leaves on his sunglasses, he answers in a monotone, he won't look me in the face, and it irritates me a little after a moment or two. Or a young woman who just can't sit still, she's so excited, and she kind of talks in a scattered way, and I have to keep bringing her back to the subject. Again, both of those might be a little bit uncomfortable for me, but it helps if I can remind myself it's only because the patient's a little bit anxious. Whenever I begin to feel emotion, then I begin to think that I may be put off by the patient's anxiety, or I may be coming up against a bias of my own. Whenever I begin to feel like something is pushing my buttons in what that patient is saying, I'm feeling a little bit hot under the collar. Because a patient can talk to me all day long about the rash on their elbows or the earache that they have, and I never feel much emotion. But in the sexual history, something that the patient tells me can sometimes bring up some emotion. What kind of things might I be referring to there? Well, let's say the young woman who comes in for a pregnancy test, that pregnancy test is negative, so I'm talking with her about contraception. She's had 6 abortions. When I look back at her chart, she's already told me that she uses speed and ecstasy when she goes clubbing on the weekends, and she is unwilling to look at any kind of hormonal birth control because she says, I don't want those unnatural chemicals in my body. Or let's say I have a male patient. He has sex with men. He hooks up with guys who he meets online and has unprotected sex, but he doesn't tell them that he's HIV positive. Both of those patients may bring up some emotion in me. And being non-judgmental doesn't mean that I condone the behaviors, but it does mean that I recognize my own feelings as biases, and I'm willing to keep them out of the way to keep talking with my patient. Finally, we try to avoid using overtly value-laden language like you should, why didn't you, I think that you should. Those things are only going to put the patient off. So finally, helping our patients to change their behavior may start with our changing some of our own. Be willing to give the brief sexual history a try. With practice, you will see improvement. Work on recognizing those biases and keeping them in check. Talk a bit less and listen more. You'll hear important health concerns that surface during the patient's sexual history. Thank you very much.